Sorry about that. Thank you. Happy to be here, and I'm going to use a few cases to illustrate what Dr. Saxena was just talking about, is the fact that this has some similarities but definite differences with adult optic neuritis, and give some discussion about how we manage these patients differently. So the first patient is an 8-year-old boy, and he noticed that he had a blind spot in his left eye, and he was otherwise healthy. He lived with his biological parents. He has several siblings. They're all in good health with no chronic medical problems. A cat and a dog live in the house as well, this being a good American household. And his vision was normal in his right eye, but markedly decreased to the 6/120 level in his left eye eccentrically. He had a left relative afferent pupillary defect. His color vision was normal in the unaffected eye, and his visual fields by confrontation looked to be normal in the right eye, and he had a dense central scotoma in his left eye. Now, the first point I'd like to make here is that doing perimetry in an 8-year-old is often successful. I have been able to get reliable perimetry in children down to the age of 5, typically girls more than boys. But by age 8, I, again, with a good technician, have had good success with a CETA fast protocol, which really should only take 4 or 5 minutes. And especially with kids, relative to the prior talk, spending a lot of time on screens and being very familiar with games and such, they will treat it as a game and generally do pretty well. This was not the most reliable field, but we can appreciate that there is an apparent inferior scotoma in the left eye, along with that central depression that was picked up by confrontation. The right eye, it's unclear if that depression is abnormal or not. Remember, though, in the optic neuritis treatment trial, we did find that 1/3 of unaffected eyes did have a visual field defect. We don't know if that applies to children or not. And speaking of the optic neuritis treatment trial in children, so this boy has a swollen left optic disc evident here, and on the right it is normal. It is quite frequent that we see papillitis, a swollen optic disc like this with obscuration of peripapillary vessels, peripapillary hemorrhage, as can be seen here in the papillomacular bundle, and additionally some evidence of congestion because of the venous tortuosity. All of these features evident just in the left eye, not in the right eye. So how are we going to proceed with this patient? Well, you can see that there might be a little fluid in that papillomacular area as well. And in the OCT age, we can appreciate that that's actually very significant here, that there's marked subretinal fluid. And one thing we see in children is more of this crossover between the idea of a pure optic neuritis and potentially a neuroretinitis. And then on the MRI, the arrows point to the fact that there is a very specific and focal enhancement at the optic nerve head itself, a papillitis, again, without really much enhancement far back in the orbit. So the arrow in the lower coronal section is pointing again to just behind the globe, where there's a tiny bit of enhancement, but otherwise nothing else. And the brain MRI was normal. So in this case, where you have a fairly young child, 8 years old, first decade of life, who has vision loss, papillitis, and no other systemic features, what are we going to do? Well, this is India, so I figured TB was obvious, so I didn't put that on the list. But we would test for TB. Syphilis, unfortunately, can occur at any age as well, so that's important to check for as well. But the typical agents, Bartonella, looking at that neuroretinitis crossover spectrum, looking for evidence of sarcoidosis. In certain parts of North America and Europe, we'll look for Lyme disease. In Colorado, where I am, Lyme disease doesn't really exist. And toxoplasma. Some people suggest toxocara, but I've never really seen that produce a true acute onset papillitis in an 8-year-old child, more of a congenital problem there. And is there evidence for treatment with a negative workup? How are we going to manage a patient like this who has an optic neuritis? Maybe it is idiopathic. We find no other positive test that points to an infectious or other inflammatory etiology. I alluded again to the optic neuritis treatment trial. There is work underway to try to do a pediatric optic neuritis treatment trial to see if IV corticosteroids have the same benefit and if they affect visual outcome down the road, but we don't have that same kind of strong prospective evidence. That said, the use of corticosteroids in patients with pediatric optic neuritis, at least in North America, has become fairly routine, and the outcomes again are being measured right now. But there are a couple of things I think that still plague us with optic neuritis, particularly in the youngest children. And that is that the time of onset can be harder to determine. Pain is often not present. It's worse with eye movement. And again, the child may not report the visual decline until it becomes fairly profound to the 660 or 2200 level or worse, or when the second eye is affected. And there again are no good data to back this up. But I have always wondered if the fact that we see more bilateral optic neuritis in younger children has more to do with the fact that younger children may not care if they can't see out of one eye as long as the other eye is still seeing okay, and don't report that problem to their parents or isn't noticed. And it's only noticed when they lose vision in both eyes and then start to be able to perform activities that they normally would. So I think a question that might be hard to answer. But if we look at the outcomes of pediatric optic neuritis, what we know from retrospective studies is that the visual field defect is similar to what we see in adults. It can be virtually anything. Their time to recovery may be longer. They may continue to recover for more than 1 year, unlike in adults where we tend to see that visual improvement plateaus by 6 to 12 months. And visual recovery is usually excellent. So one observation has been that pediatric optic neuritis in general, the visual acuity at presentation may be worse, but the recovery may actually be better compared to adults. And almost all of them seem to get back to excellent visual acuity. We'll talk about the exceptions. And recurrence is variable, and we will get into that as well with the next two cases. The second case is a 14-year-old white Caucasian girl with Northern European extraction who had pain with eye movement in her right eye, and then about a week later noticed some dim, blurry vision as she described it. She, like the previous patient, was also otherwise healthy, had no other ocular or medical history. She was doing well in high school. She had no pets at home, and she had a cold 2 weeks ago. This was in the pre-COVID era. And her vision in the right eye is mildly reduced to 618, normal in the left eye. She has a right RAPD, and her color vision by Hardy-Rand-Rittler plates was diminished in her right eye only. And the remainder of her anterior exam was unremarkable. At this point, she said that her pain with eye movement, while it was still present, wasn't really what bothered her. What brought her in was the fact that her vision had declined. She did a nice, reliable visual field, and in her left eye, the unaffected eye, it is normal. And in the right eye, we see not that different from the 8-year-old I showed you. There's a decreased foveal threshold. There is, in this case, a superior, somewhat altitudinal defect, along with evidence for a central or secocentral scotoma. So characteristic of what we see in patients, adult patients with optic neuritis. And her fundus exam, there's perhaps a little bit of swelling, minimal of the right optic nerve, but it's not impressive. It is, again, more similar to what we see in adults with typical retrobulbar optic neuritis that occurs frequently in North America and less frequently, although still happens in Asia. And if we look with OCT, just to show that in this case, the macula is not affected at all, at the right side of the cross-section, you can see that there is some thickening of the peripapillary retinal nerve fiber layer. I don't personally find scans of the retinal nerve fiber layer to be particularly useful in acute optic neuritis. It can be useful chronically. So in this case, we got an MRI scan of the brain in orbits, as one would, and the MRI shows anterior enhancement of about half to 1/3 of the intraorbital optic nerve. That's shown here as well on coronal section. There's not really enhancement of the optic nerve sheath. The stripe that you see on the axial section was the artery, and her brain MRI was normal. So of course the question that the parents have is, will my child get multiple sclerosis? They go and ask Dr. Google, and Dr. Google tells them about multiple sclerosis before they even come in to see you. Optic neuritis treatment trial again. We know that in adults, the white line at the bottom showed the risk of progression to multiple sclerosis in patients with no MRI lesions. The green and yellow lines show you the risk of progression in 15 years with MRI lesions. This was in the pre-gadolinium era, pre-flare era. So the rate of everyone progressing to multiple sclerosis is lower now than it used to be, even with abnormal MRI. And in particular, those who have a truly normal MRI, their risk of progression to MS is much, much lower than the 25% here. But how about in children? What predicts that risk of progression to multiple sclerosis? It was thought in some retrospective studies that bilateral versus unilateral optic neuritis was predictive, or the age of onset of the optic neuritis was predictive. So there have been, I think, two good studies that have evaluated this, and a number of smaller studies, not that they weren't good, but these are large studies, one a meta-analysis published in 2011, and one a larger retrospective study done in 2015. Looking at these various factors, do they have a viral program, how much did they recover, what did their MRI look like, did they have abnormalities on MRI, and also did they get a lumbar puncture, and were there oligoclonal bands present? And in the first study, it was suggested that 40% of patients developed MS after 4 years. And in that study, the youngest patient was 4 years old at the onset of their optic neuritis. And the median age, though, for progression to MS was much higher at almost 15 years. And there was an increasing risk of multiple sclerosis with increasing age of presentation. But bilateral versus unilateral presentation in neither study was predictive. The greatest predictor was MRI. And in the retrospective meta-analysis, it was suggested that there was a 25-fold increased risk with abnormal MRI, but not all patients in that study had MRI. In the more recent study in 2015, when all the patients had MRI, the MRI was predictive, but also oligoclonal bands were highly predictive. So having positive oligoclonal bands or having positive MRI gave you about a 3-fold increased risk of multiple sclerosis. But the two together had conferred a 26-fold risk of multiple sclerosis compared to those who had neither oligoclonal bands or an abnormal MRI. So my suggestion is getting MRI and getting a lumbar puncture on these patients is going to be highly predictive of their risk of progression. Finally, this last case, a 12-year-old Black girl who was in school, and in the morning she was fine, but by the end of the day could not see her way back to class. Again, otherwise healthy, a family member with glaucoma, she's doing well in school, she has a healthy sibling and no pets. She has hand movements in one eye, counting fingers in the other eye. Her external exam is unremarkable. She has sluggish pupils, a subtle left RAPD. Though the vision was worse in the right eye, she couldn't see the Hardy-Weyand-Riddler plates, of course. Her fundus examination was completely unremarkable. No optic nerve swelling, no hemorrhages, and visual field, she couldn't see the bowl out of her right eye, and the test was terminated. This is why I think OCT is not particularly useful in the acute phase. It doesn't tell you anything other than the fact that probably she's never had this happen before. More important, the MRI findings in this patient. So this patient had no pain. She had no other symptoms other than vision loss. And at first, it was because she was 12 years old, it was suspected maybe this is functional, but get the MRI and do a good exam. She had an APD, it's not functional. And she had enhancement of both optic nerves in the intracranial space, and particularly going back toward the optic chiasm. So posterior bilateral avid enhancement of the optic nerve bilaterally, and the MRI of the brain itself was normal. So what additional studies do you want to get now? Well, here, a spinal MRI was done. It was normal of the cervical and thoracic spines. We're looking for the kind of abnormalities you see on the right, of course, longitudinally extensive transverse myelitis that might give us a diagnosis of a disorder like neuromyelitis optica spectrum disorder. And NMO spectrum disorder can occur in children, certainly does. There are cohort studies that have been reported. They tend to present in a similar way, and we still don't know about the role of long-term immunosuppression in those patients in terms of how long they would need to be on that, because if you start a 10-year-old on immunosuppression, are you going to keep them on that for 70 years down the road? So some vexing questions there, I think, that I don't have the answers to yet. MOG, myelin oligodendrocyte glycoprotein antibody, was actually first reported in children with optic neuritis less than 10 years ago, and of course in adults less than 10 years ago as well. And there is a crossover between MOG positivity in patients who have conditions like ADEM acute demyelinating encephalomyelitis picture, and those who have isolated optic neuritis. And we are still learning about the role of MOG and the need for long-term treatment or extended steroid treatment in children who have MOG-positive optic neuritis, because it has been shown that only a minority of patients who have MOG-positive optic neuritis have MRI abnormalities. There's, again, that crossover with ADEM, but the need for long-term therapy is not as clear as it is with NMO. And the role of lumbar puncture, again, looking for other inflammatory disorders, looking for the presence of oligoclonal bands may be useful, even in patients like this, to try to differentiate among the potential underlying causes for this severe vision loss, and helps you to know when to institute therapy. There's evolving literature in adults about the importance of starting therapy very quickly, corticosteroids and possibly plasma exchange in those patients who have NMO spectrum disorder, because of the poor response after even 2 or 3 days of onset of vision loss. So overall, optic neuritis is less likely to occur in children than in adults, but has a wider range of causes. The visual outcomes tend to be good, and our treatments really are extrapolated from adult studies. We don't have the same kind of prospective treatment data. MS risk in those patients with retrobulbar optic neuritis are related to MRI findings, oligoclonal band positivity, and a slight effect of age. The older they are, the more they're going to be like adults in terms of their risk of MS. You definitely want to consider other causes in higher risk patients, Asian patients, Black patients, those who present with atypical symptoms, and we can perhaps discuss the role of long-term treatment in patients with atypical optic neuritis. Thank you very much.